Hello there. My name is Nicholas, and I will be presenting on bipolar disorder. I chose this mental health issue because someone very close to me has bipolar disorder, and I thought it would be important to research the topic to help grasp their situation and future clients of mine. So I'm going to start with defining bipolar disorder, and then we're going to look at a graph that kind of helps compartmentalize bipolar, and then we're going to look at the difference between bipolar 1 and bipolar 2. And then we'll move into the impact bipolar has on healthcare by examining the impact it has on healthcare quality, such as client outcomes, and the impact it has on the safety of patients, families, and the healthcare team. We'll look at regulatory factors such as policies, laws, and reimbursement factors. And then we'll look at associated financial costs and what we as nurses can do to engage in social justice advocacy for these patients. So, what is bipolar disorder? So, bipolar disorder is a mental health illness that presents in cycles of mania and depression, or fluctuations between mania and depression. 4.4% of Americans have bipolar disorder, and 82% of those cases are considered severe. The average age for onset of bipolar disorder is 25. However, many individuals go on for years without an accurate diagnosis. And the onset of bipolar disorder tends to occur later in women than it does in men. However, the fluctuations between mania and depression in women can be more extreme. And interestingly, the occurrence of bipolar disorder appears more in higher socioeconomic classes. Okay, so here we have the bipolar graph, or what I've called the bipolar continuum. And it categorizes the diagnostic criteria for bipolar into four subgroups: mania, hypomania, minor depression, and major depression. So, as I mentioned earlier, bipolar disorder is characterized by the mood swings from depression to extreme euphoria or mania. And then there's often, intervening periods of normalcy. So on this graph, we see that bipolar 1, the red line, goes into mania and then dips down into major depression. And then bipolar 2 hits hypomania, but it doesn't actually go into mania. And then it does go into major depression as well, but it doesn't ever get into mania. And then cyclothymia is a more mild version of bipolar 2, where it's constantly going from hypomania to minor depression, but it's never reaching either extreme. So bipolar 1, as I mentioned before, is an individual who experiences the extreme mania and then goes into an episode of major depression. The diagnostic criteria for bipolar 1 is dependent upon only one episode of mania. And that can be specified by the current or the most recent episode experienced. So there's the higher intensity fluctuation of the mania to major depression. So then bipolar 2 is the reoccurring instances of depression with episodes of hypomania, so not ever getting into the mania extreme. And the DSM-5 definition of hypomania is a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and an abnormally persistent increased activity or energy that lasts at least 4 consecutive days and is present on most of those days or nearly every day. A bipolar 2 patient will never have experienced an episode of full mania. So now we're going to be looking at bipolar in the healthcare context and how that has an impact on healthcare quality. So in the acute care setting, such as a psychiatric unit or in the ED, the healthcare team is going to want to focus their priorities on the restabilization of the patient's mood. So assessments of depressive disorders, since bipolar disorder manifests symptoms holistically, meaning that the symptoms affect the physical body, mental health, and the spiritual well-being, assessments should revolve around self-worth, physical well-being, and the spiritual sense. And then looking at assessments of manic episodes, the healthcare team is going to want to assess the patient for inflated views of self, elevated mood or irritability, so excessively cheerful, or showing irritability over small things that people normally wouldn't get excited about or irritable about. Increased self-attitude. So, for example, someone who is usually reserved, speaking overly critical or judgmental at inappropriate times. We're going to want to look for increased vital sense. So lots of energy, tirelessly working to the point that would normally exhaust somebody who is not suffering from bipolar disorder. Going to want to look at spiritual issues. So like spiritual distress or losing faith in God or their spirituality in general. Decreased appetite, like too busy to eat. Suicidal ideation, so like hyperactivity and psychotic thinking can increase the risk for suicide. So the healthcare team is going to want to ask questions like, have you thought of hurting yourself? Have you been thinking about suicide? And do you have a plan? Okay, so now we're going to be looking at some patient outcomes for patients with bipolar disorder. One patient problem could be the potential for harm to self or others, as evidenced by increased impulsivity and agitation. So an outcome for that would be by the time of discharge, the client will be able to show increased self-control and decreased impulsivity. And then another patient problem could be the potential for a knowledge deficit due to unfamiliarity with the bipolar disorder signs and symptoms and the treatment related to that. So an outcome for that could be within 48 hours of admission, the patient will be able to verbalize 2 signs and symptoms of bipolar disorder and will be able to explain at least one treatment option. Another patient problem could be the potential for decreased self-care due to lack of regard and impulsivity. So an outcome for that would be by the time of discharge, the patient will be able to perform activities of self-care. And then finally, another patient problem would be like the potential for weight loss due to decreased nutritional intake caused by an episode of mania. So an outcome for that would be immediately after nursing interventions, the patient will show increased adherence to dietary intake. So now we're going to be looking at the impact bipolar disorder has to the safety of the patients, family members, and the healthcare team. So the bipolar patient's safety can be jeopardized by impulsivity and aggression induced by mania, which could result in self-harm. So suicidal ideations are 10 to 30 times more likely to occur in individuals with bipolar disorder, and actually 20% of bipolar disorder patients do take their own life. Bipolar disorder may jeopardize the family's safety in a handful of ways. the family may be put in situations where they might need to confront unusual or dangerous behaviors. Um, Patients who have bipolar disorder are more likely to have reported being involved in a crime. Um, Additionally, family members may experience mental distress through grief or worry for their loved one that is experiencing an episode of mania. Depending on the family member who is affected, if it's a parental figure or a guardian, then the children might experience some role safety or role distress, um, where they may experience abrupt role changes in the family where they need to be put in a position that makes them responsible for their parents' actions. In addition, when manic bipolar individuals have these episodes of mania, they can spend large amounts of money without considering the consequences. So if a parental figure were to do this, they could place children or other dependents at risk of like inadequate dietary intake, because they don't have enough money, or loss of utilities like heating, water, electricity, because the bills have not been paid. Due to the impulsiveness experienced by bipolar patients, the healthcare team could also be placed in situations where a bipolar patient experiencing or exhibiting symptoms of mania, such as aggression and agitation, may place that healthcare member or healthcare team in a unsafe position where they are in harm's way, or that patient wants to hurt them. So, looking at regulatory factors, one specific policy that was enacted by the Americans with Disabilities Act actually allows for bipolar individuals to be eligible for ADA accommodations through the Job Accommodation Network. So if a bipolar disorder interferes with an individual's ability to acquire or maintain employment, they may be eligible for coverage under the ADA, and employers are required to make accommodations for bipolar employees. So some accommodations include things like a flexible schedule, modified break schedule, rest area, private space, or even work leave, but that's a pretty last case scenario. And then for the eligibility guidelines for mental health in general, to be eligible, you need to have depressive syndrome characterized by at least 4 of the following, or manic syndrome characterized by at least 3 of the following. And so for the depressive ones, it's loss of interest in activities, change in appetite or weight, changes in sleep pattern, agitation, decreased energy, feelings of worthlessness, or thoughts of suicide. And then for the manic characteristics, it's hyperactivity, pressure of speech, flight of ideas, inflated self-esteem, decreased need for sleep, easily distracted, and hallucinations or paranoid thinking. So now we're going to look at the regulatory factor for patients with bipolar of Social Security. So similar to the ADA, SSA, or the Social Security Administration, does consider bipolar a disability. But this is for patients or individuals who have worked and have a new sudden onset of bipolar disorder. They can apply for SSA. So the patients must have a history of reoccurring manic episodes with depressive episodes. And then additionally, they'll need to meet work requirements to get SSA benefits. So, some things that can contribute to eligibility is severity of the inhibition of daily activities, the inability to interact with others normally, and reoccurring episodes of decompensation lasting extended periods of time. So if you meet the requirements, patients can get monthly benefits that are paid if you have the medical condition and if it's expected to last at least a year. So financial costs associated with bipolar disorder in the United States comprise of direct non-healthcare costs, direct healthcare costs, and indirect costs. And I'll explain what those are in a moment, but all of those collectively have a total national economic burden of $219 billion. Direct healthcare costs include things like Medicaid claims, outpatient care, ER use, hospitalization, prescription use, and frequent psychiatric interventions. And that makes up 23.2% of the national economic burden of bipolar disorder. Direct non-healthcare costs, which are primarily comprised of the criminal justice system, include the costs of incarceration, policing, and legal costs, and that makes up 4.4% of the national economic burden of bipolar disorder in the US. And then indirect costs include things such as unemployment, caregiving productivity loss, work productivity loss, and premature mortality, which occurs frequently in individuals with bipolar disorder. And that accounts for 72.3% of the national economic burden associated with bipolar disorder, which is a whopping $158 billion. So, how can nurses engage in social justice advocacy for patients with bipolar disorder? Well, according to our book, there is a real people, real stories interview with a bipolar patient. And one of the questions that the nurse asked the patient was, how can we be more understanding, and how can we provide better care for patients with bipolar disorder? And the patient said that the number one thing is to be a good listener. Oftentimes bipolar patients who are experiencing mania have flight of ideas. They're talking a million miles a second, but in those instances, there is sometimes a kernel of truth. So being able to find that is really important for bipolar patients because it makes them feel heard. Being compassionate is the second thing that she said, in that patients can always tell when you are being insincere, or when you they can tell if you are there to help them or if you're not there to help them. And then the third thing that she said is to look the patient in the eyes and call them by their name. Bipolar patients who are experiencing mania often feel lost. And so when you make that connection with them, even though it may not seem like it's helping, it makes them feel less lost and more grounded. And that can be really helpful in helping them control their symptoms. And then educating yourself and others about bipolar disorder, connecting with the patient and connecting the patient with resources such as a crisis hotline, a support group, individual psychotherapy, or legal and financial assistance, and then providing sensitive patient-centered care like trauma-informed care. A lot of bipolar patients live lives normally, much like everybody else does. And when they do go into these instances of mania, it can be traumatizing for them. So understanding that care that they have trauma as well, they carry that, can be can help you connect with that patient and can hopefully allow you to better engage in social justice advocacy for bipolar patients.